Hey, if anybody's out there, can you hear me? Well, even if I talk to myself, that's okay because I do a lot of that. But I just got out of work about an hour ago. Was supposed to be done at 5 o'clock and walked out the door at about 7:15, and it was just another draining draining day in the emergency department. And here I am supposed to talk about nursing school and perhaps why you should go or maybe why you shouldn't go. And after working, I don't know, about 13 and a half hours, I don't know if I should talk anybody into going into it or not. I don't know. Well, while we're waiting to see if anybody shows up, I'm going to do a little bit of reading. A little bit of reading off the news here. And the first thing I'm looking at, now this is off of NPR, and I don't listen to NPR routinely. But this is, I try to be a body positive doctor. It's getting harder in the age of Ozempic. And it says, right around the time that Ozempic came out, I started to change the way I practice medicine. As a new class of weight loss drug ushered in a highly medicalized area of America's obsession with being thin, I decided I was done with trying to get my patients to lose weight. Sometimes I call myself a body positive doctor, but that isn't it exactly, because I don't expect all of my patients to love their bodies all the time. With my students, I call it practicing weight neutral medicine. I found a great community of like minded healthcare providers with the Health at Every Size movement, which promotes the idea that people can be healthy without focusing on weight loss. Well, the first thing I can say about that is that I agree. Weight loss, like actually measuring yourself on the scale, obviously isn't the best way to determine if you're getting healthier. overall fat loss is, I think, what most of us strive for, but that often isn't reflected on the scale. There's so much fluctuation in water weight, and that's something that I know I get quite a bit. So let's see, we've got starfish here. I'm in my second to last semester of nursing school and work as an extern, having second thoughts on it. So tell me more about that. Why are you having second thoughts? What's going on that's giving you second thoughts? You're in your second to last semester. You're almost there. What's been going on? I know that sometimes when you finally get into your clinical rotations and you're taking on more patients and you start to get a little idea of what you're up against, and of course you're getting more patient contact, so you're coming across people that are not always in their best and not always treating you the best. And I think that gives people sometimes a little bit of pause whether they want to complete the program and become a nurse. I understand it. And med surg is tough. I remember my med surg rotations. I was not a fan. But to be honest with you, I wasn't a fan really of almost anything in nursing school, to be honest. I simply did it because, first of all, it was free. It didn't cost me anything. And I figured, well, this is an opportunity to get an education without it costing me anything. Because back when I went, it was free tuition if you agreed to work for the hospital for a certain amount of time. So for me, it was like a means to an end, but I don't think I enjoyed a single day in nursing school. So Schmitty the kid, you're graduating in May, so that's right around the corner. What are you guys planning on doing? If you do finish, what do you plan to do? Do you plan to work med surg, work on a floor for a year, try to get directly into an ICU? What are you thinking of doing? I can tell you my first job, and I think I was the first new grad to get hired, but my first job as an RN was working in open heart ICU, cardiopulmonary ICU, and it was actually that was really good. I was there for 6 years, and it was all, it was drips and machines, and patients came directly from the OR right into the ICU. It was like a recovery room basically for open heart. And, the nurses really managed the patient pretty autonomously. We managed their cardiovascular status. We had pacer wires in everybody. We had left atrial lines. We had swans, which I don't think swans are even used a whole lot anymore. But those were ways of measuring central venous pressure and indirectly measuring left atrial pressure, which allowed you to titrate your vasoactive drips more accurately. It was kind of fun. It was very technical. And on top of that, though, we gave good bedside care. I mean, these folks, for the most time that they were in the ICU, they were unconscious. I mean, most of them were on propofol drips until we decided in the morning that we were going to try to extubate, and then we would dial down the propofol and allow them to wake up gradually, and and then eventually extubate them in the morning. It was a long time ago. I left that type of work in 1996, and that's when I became an NP. And my first NP job was working in a medical intensive care unit at a neighboring hospital, which was not nearly as technical or highly acute as where I came from. So it really was a good transition to go from being an RN in CPICU to nurse practitioner in medical intensive care. But let's see here. So Starfish, you're gonna finish. That's good. You're gonna work rehab and ortho, and then cardiac step down. I mean, those are all interesting things. Rehab has become such a big thing. Uh, a lot of the area nursing homes have transitioned really to full service rehab centers that do take elderly, but also take people that just aren't ready to go home yet, and they might need a couple of weeks or maybe a little longer than a couple of weeks of getting their strength back. So rehab centers have become in demand, and having good nurses working in those rehab centers, I'm sure it's hard to find, just like with anything else in nursing right now. So Schmitty, you're going to go directly to the ICU, and you hope that your capstone is going to be in the local ICU, and then work for a few years, and then CRNA school. And I think maybe you had messaged me about that. Sorry, man, it's been 13 and a half hours of working today, and I'm I'm at the end. But I'll tell you, if I had any regret whatsoever, I think the regret was not becoming a nurse anesthetist. And that was not really the reason why I worked in open heart ICU, but it became a good reason to stay in open heart ICU because it was a great transition. It gave you that ICU experience that you needed on your application for a nurse anesthetist program. And so I really thought that that's what I was going to do. And unfortunately, there wasn't a CRNA program in my town. There were some in neighboring towns. But at the same time, back in the day, I was looking at my finances and saying, well, I could stay where I am and go on and get my graduate degree. I went to Syracuse University for my bachelor's and my master's degree. And I could stay there and I could get my nurse practitioner at SU. And of course, SU doesn't have a program at all anymore. But I decided to stay at SU. I was really thinking about going to Buffalo and getting my CRNA, but I didn't. So I became an NP. I mean, the cool thing is that, I know how to treat a lot of different conditions, but the CRNA, I mean, it's decent lifestyle. You make good money. No complaints. No complaints there. Everybody I know that's become a nurse anesthetist is pretty darn happy that they did. And you currently work, Schmitty, as a procedure scheduler in the hospital endo department. So you kind of get to see a little bit of the inner workings of how the hospital works. That's good. Are you going to work in the same hospital, you think, that you're working in right now, or are you going to switch to a different hospital? And Schmidt, you say that this is a second career for you. Yeah, you didn't know CRNA was a thing. I don't know if I did. When I first started nursing school, I don't know if I was really aware of it either, but I became aware of it pretty quickly. I know one of the nurses that worked in open heart ICU with me, her sister was a CRNA. And this is back in 1990, 1991. And I remember her telling me that her sister got like a $10,000 bonus at Christmas time. Now, in 1990 or 91, $10,000 was a lot of money. It's a lot of money today, but it was definitely a lot of money then. And that was a Christmas bonus. And that's when I started to realize, hey, wait a second, maybe I should be taking a look at this CRNA thing and see what that's all about. And honestly, Back then, the other CRNA programs that I was looking at, there was one in Scranton, Wilkes-Barre, Pennsylvania. And that was a program where essentially you lived in the hospital, you got paid a stipend. There was no tuition, but you were there all the time. I mean, you were like a physician resident, basically. You You were there, you were on call all the time, you lived in the hospital, but in return, you got your education and you got a little stipend to live on. You didn't come out with a degree. I mean, there was no graduate degree offered, but still, pretty good deal. I'm sure they don't exist anymore. I know that that program doesn't, but uh, again, another opportunity that I probably shoulda, coulda, woulda taken care of and taken advantage of, but didn't do it. And so your girlfriend is an NP at the VA. I've got a couple friends that work at the local VA here in town where I'm at, and they're pretty happy with benefits and all of that. I'm not. I work in a state hospital, but I'm not a state employee. I'm an employee of our physician group, which contracts to do emergency medicine and a few other things in the hospital. So I don't get some of the benefits that the state employees get, like retirement. I don't get a state retirement system benefit. But what I do get is I get a large donation into my 401k every month from the group, and I think that probably offsets it a little bit. But if you can get into a good system like a federal or a state system and get a good retirement and find a job that you're happy with in that hospital, you know, from my perspective, being my age right now, I'm all about retirement. So don't ever forget that at some point, someday, you're going to get older and you're going to want to retire. So try to take advantage of it if you can. Yeah, and Schmitty, I know you've commented on a few videos, and I appreciate that. I try to read them. I try to read as much as I can, but man, I tell you, I would love to get more involved in YouTube and making videos, but it's so hard to do, you know, when you're working full time. And I work at least two shifts a week in the emergency department, sometimes three. And then I have one day a week that I have my own patients in the wound clinic, which is actually under our department, but it's a separate part of the hospital. And then I finished training in undersea and hyperbaric medicine over the last 3 years and did my final exams in Salt Lake City in March and passed those. And so I completed what was called the PATH program, which is a program for advanced training in hyperbarics. And our program here in my town is a 24-hour hyperbaric center. So we're an emergency on-call hyperbaric center. And we're under the Department of Emergency Medicine. So between hyperbarics, wound care, and working in the emergency department, and my job is the admin for the PAs and the nurse practitioners, and I run the fellowship program in emergency medicine. I wind up, if I'm working on something like videos, it's usually late at night with practically no sleep, and I'm getting old. I'm getting too old for that. Yeah, you know, a lot of guys, it was a second career. There was a guy that worked in the ICU, not in cardiopulmonary ICU, but he worked in the med-surg ICU back in the early 90s. Great guy, but he was an auto worker. And back in the late 80s, early 90s, there was a lot of layoffs going on in the auto industry, and he had just gotten tired of constantly getting laid off and then being called back, and the lack of predictability. And so he wound up going to nursing school, became an RN, and he was a great guy. He just retired just a couple of years ago. He worked the emergency department for quite a few years. He worked in intensive care, and then he came down to the wound clinic, and he worked in the wound clinic with me for the last couple of years before he retired. But listen, it's a great second career, third career. I've known guys back in my paramedic days that were cops, and as soon as they retired, they went to nursing school. I know 3 of them that went to nursing school, got their RN, and I think because of their age, wisdom, and experience, they immediately went right up the ranks to administrative type jobs and did very, very well. I think they're all retired now too, actually. But so my girlfriend always talks about the benefits of the VA. It's a running joke. Yeah, I know that VA benefits are pretty darn good. I remember I interviewed for a VA job once just for the heck of it. I was curious, and it was I think it was with the surgery service or something. And of course, I went in there and thought, that I was going to get paid a lot more than what they were going to offer me, and I think I wound up blowing them a little attitude or something during the interview, and I think they said, no thanks, we don't need you. So I never got an offer to work at the VA, but I did interview once, way back when. It's always good to interview every once in a while, keep your skills up with interviewing, and I think it's always good to keep your eyes open as to what's available. You never know what's around the corner, and that brings up a different topic that, back when I was younger, I thought that it was a sign of loyalty to work in one place for a long period of time and never leave, and that would be admired. And it obviously isn't anymore. I mean, a lot of people will work a year here, 6 months there, 10 months there, and it's not looked down upon. It's looked upon in a positive light that, you're bringing a lot of diverse experience to the table. So I guess that's the way to go nowadays, is keep your eyes open and keep looking around, and don't be afraid to make a move. I think if you've been in a job for 5 years or more, it's probably time to start looking around, because you've probably achieved most of what you're going to achieve in that position anyway. So I think the 5-year mark is where you should start looking. Now, I've never taken my own advice on that, but for others, I think it's probably a pretty good idea. Starfish says, I think nursing school prepares you for the NCLEX. Working as an extern, I've learned more and more opportunities about time management. And time management is the key. And I mean, just today, in the emergency department, we had, today's Wednesday. And on Wednesdays in our department, our residents are in conference all day. And so the only people that are working in the emergency department are 2 attendings and usually 2 APPs, PA or nurse practitioner. We're a level 1 trauma center. We're a referral center for 19 county area in New York. And so we can get pretty busy pretty quick. And that's what happened today. And it some days it's just when you think, okay, it can't get a whole lot worse than this, the EMS rolls in with an unannounced cardiac arrest, difficult intubation, and then there's a stroke code, and then you get a call over the radio that they're flying somebody in on a helicopter. I mean, this is kind of a daily thing, but if you're a nurse working in that environment, you have to have time management, because a lot of the nurses that are taking care of 3 or 4 patients, one of them is probably also reserved for the trauma room, and they have to drop everything they're doing to go into the trauma room and take care of that trauma. And you have to have all your ducks in a row. You have to have your patients already put away. You can't let things slack. So time management is a big thing. Let's see. Gotta feed the algorithm. Let me tell you, I appreciate it, and I really hope that someday, maybe someday soon, I can find a way to spend more time doing this and to make videos that are a little more interesting. One thing that I find interesting, and I don't do enough of it, is just reading the news when it comes to healthcare type news. I don't think many of us have the time to do that. So I'll scroll through like Medscape and even Apple News. I'll type in like, health news on Apple News and just start reading some of the stuff that other people are reading, that lay people are reading. And some of those things I want to share with all of you because I know that most of you don't have time to read this stuff either. So I think that's kind of what I like to do on this channel because it gives you a chance to just kind of throw information out there that maybe you haven't come across, and then it gives us a chance maybe to talk about it. And like I said, as things kind of roll on, we can start talking about things a little bit more, using the comments section to kind of bounce things off of each other. And, it's Starfish, you mentioned the NCLEX. And I'll be honest with you, I never took the NCLEX. That came after me. I took a state board exam that was a 2-day exam, and it was a written exam. And, how that relates to the NCLEX, I'm not sure. But I know that exam was not, it wasn't hard, but it was just long. It was very long. And I don't think it was really hard because, to be honest, when I took that exam, I was still working as a paramedic in the city. And of course, my buddies thought that they would do me a favor. And the night before the exam, they decided that they were going to take me out. And of course, we went out. And, I think I rolled in at 2:30 or 3 o'clock in the morning, and I had to be sitting for the exam at 8 o'clock in the morning. So I was pretty well prepared for that exam. And that was all thanks to my friends. But hey, I passed. So that's all that matters, I guess. So, Schmitty, you graduated in 2009 with a BS in psych. You were a pre-med student at the time, but didn't have the GPA, so you joined the Peace Corps and went to Ethiopia. That's interesting. Wow. I would be too chicken to do something like that, but that's really cool. And as far as the GPA and med school, here's the thing. You can always, down the road, as you get older, decide, okay, maybe I do want to go to medical school. There's pathways that I've learned about after the fact. As a matter of fact, at our medical school, there's a pathway where you can come in, you can take a prescribed set of coursework, and it's usually like higher level bio and stuff like that. And if you do well, you're almost guaranteed acceptance. You're at least guaranteed an interview, and there's a pretty high acceptance rate. So there are pathways, even for folks that maybe their GPA wasn't so good when they were in undergrad or whatever it is that they did. If you're determined at some point in your career that you want to become a physician, it's never off the table. And I would say this to any nurse practitioner, any PA: don't ever take that possibility off the table, because for some, it's cool to just train to do what you do, and you can be very happy as an RN or as a NP or a PA. But for some people, once you get into that mindset of continuous learning and reading and you enjoy it, you might want to advance your education further. And I've known plenty of people that were nurses that went on years later and went to medical school and did very well. And they're very good physicians because they know both sides of the story. They know how the nursing field works and the nursing world. So I think that's something to always kind of keep in mind. And Schmitty says you're not the oldest in your cohort. And that's, when I was going through it, I wasn't the oldest. Now that I look back on it, there were plenty of people that were older than me. But when I got my PhD, I think I was the oldest in that cohort by a few years. There were a few people that were fairly close to my age, but these were all people that were professors. Pretty much my entire PhD cohort was college professors that were required to get their PhD in order to maintain their tenure track. And then there's me sitting there. And I remember on the first day, they're like, "What are you doing here? I mean, you don't need to be here. What are you doing here?" Because I made it pretty clear. It's like, I don't have a whole lot of desire to join the faculty as a nursing professor. I had dabbled in the adjunct world of nursing education, and so I kind of got my fill on that, and didn't have a lot of interest in ever joining a nursing faculty. Thank you very much. Yeah, the Peace Corps, that's sweet. I'd love to hear more about that. And Ethiopia, that's pretty cool. So the VA does not have an ICU. Yeah, I'm thinking about it now. I don't know if the VA where I'm at actually has an ICU. I've never heard of it. Maybe they do, but I don't. Well, I don't have any connection with that hospital, so I really don't know. So based on my Kaplan scores, I'm on track to pass the NCLEX, but our final semester is capstone work and studying for the NCLEX. Yeah. Yeah, you got to study for the exam. You have to jump through that hoop. You got to get that over with. What I think is, and I've mentioned this in a couple of videos, what I think is going on in nursing programs, though, is that they're so focused on the NCLEX that they've kind of taken away some of the clinical experiences that I think nursing students used to get back in the day. And I've mentioned that when I was, when I was going through my diploma nursing program, it was essentially it was a 3 year straight through, 3 years nonstop, even the summer. But the summers, pretty much you were like free labor. You were working 8 hours a day, I think 4 days a week on the floor. And you had an instructor there, but you were carrying maybe not a full workload, but you were carrying probably a half to three-quarter of what a floor nurse would carry. And so you really got an idea what it was like to work. But it also gave you good clinical experience. When you graduated, you had no problem, giving an IM injection or putting a Foley in. And I know nurses that made it through school, the entire nursing program, having never given an IM shot or having never put a Foley in somebody. But in the program that I went through, yeah, you didn't have a choice. You did it. You had to do it. So I have psych and management. My last semester, we take HESI, and it will give us preliminary score. Then we take it before we graduate. Now, HESI, here's the thing. This is where I'm going to sound disconnected. But again, when I was in my PhD cohort and all of these people were nursing professors, they were talking about these computer-based programs that I guess every student uses like throughout the program to kind of measure their success and essentially prepare them for the NCLEX. And I'm assuming, is HESI one of those? I think it is. I think that's a name that I've heard before. Yeah, I'm pretty sure that was one of the things that I'd heard them talk about. So your nursing school does 16 hours of clinical for 10 weeks. Okay. So 160 hours, right? Am I doing my math right? It's been a long day, but I think that's 160 hours. Yeah, so think about 160 hours, and so basically that's 4 weeks of full-time work as a nurse. And so it gives you an introduction, but I think for some people it doesn't really give them enough of a wake-up call as to what they're going to be doing when they graduate. Yeah, I mean, we worked, what was it? June, July. It's like most of June, July, August, right up until right after Labor Day. So that was 12 weeks. And we did, 32 hours at least. So it was pretty significant. And we did that for 2 summers and then also the final semester of the diploma program. So we probably did 700 or 800 hours. No, I had probably even more than that of actual clinical time. All for free, unpaid. But no, for free in the sense that I never had to pay for nursing school. That was the beauty of it. I had to sign an agreement saying that I would work for the hospital for 3 years after I graduate. But that hospital had to offer me a job within 6 months of graduation. And we were in the first cohort where that program was in effect. And what I did was I graduated from nursing school in December of 1989. And I waited until the end of May 1990. And they never offered me a job. It was like radio silence. I kept working as a paramedic because I was very happy, working as a paramedic for the fire department. And then the job came up with open heart intensive care at a different hospital, the hospital that I work at now, actually. So they didn't meet their contractual obligation. And, the strange thing is I never heard anything from them. So it was probably a little bit of a mismanaged program back in the day. But in any case, I would assume that the statute of limitations has run out now because it's been how many years? It's been a lot of years, 30-some years. So I don't think they're going to come after me now. But I think the total tuition would have been something along the lines of like $4,000 or $5,000 for those 3 years, combined all together, total. So not bad. Emprix is loving the stream. You should try it sometime. I've got some ideas for you to try streaming. So Schmitty says we can space things out depending on our preceptor's schedule during the final semester. A lot of people bust out a bunch of hours over spring break and are done by March. Now, you don't have to get like your own preceptor or anything, right? I mean, the school provides you with a preceptor, right? One of your nursing instructors, I would imagine. Because that leads me to another topic that I was talking about today. But I was working in the ED today. It's obviously, like I said, it was busy. And yeah, preceptors are provided. Yeah. One of my PAs, he's a great guy, very knowledgeable guy, and very into education. And he has kind of taken a bunch of PA students under his wing, and he's precepting several. So pretty much every day he has one or sometimes two PA students that are with him in the ED. And today was one of those days where he found out that it was just too much. He had too many things going on. Too much was happening too quickly. He couldn't give those students the time that they probably needed. He had them going and seeing patients, and then was trying to keep track of what they were doing and what he was doing and all the things that were changing in the department. And so he said to me, he said, geez, should I be doing this? And I said, no. Here's my philosophy on nurse practitioner and PA preceptorships. You're paying a tuition to go to a school, and yet that school is relying on practitioners out in the community to provide essentially free education. And as long as you're willing to provide free education, they'll keep taking advantage of it, and they'll keep collecting the tuition from these students. I mean, let's be honest. A lot of these students, they're going to learn maybe 1/10 of what they need in the classroom. The other 9/10, they're going to learn in the clinical setting from you, and you're offering it for free. And in return, I've done it. I mean, I did it for years. I precepted PA and NPs, and I would be offered like a gym membership at the college or the university, or I would have access to their library or something like that. I mean, something that I would never take advantage of. And that's pretty much it. That's all I ever got. Now, I guess right now, this PA that I'm talking about, he negotiated with some of the schools to pay our department $500 per student that he precepts. So he's bringing some money in for the department, makes the department happy. But even so, $500 to precept a PA student for, I think it's like 300 hours or something for each student. I mean, that's not a lot of money compared to what these students are paying in tuition to go to these PA programs. So I'm not a big fan of giving away that kind of time and knowledge for free. That's, and I didn't used to think that way, but I do now. Excuse me. Shimini says, I've been lucky with all the preceptors that I had so far during my clinicals. Other classmates have had less than stellar experiences in different departments. Yeah. My thing is this, that if the school paid the preceptor, then the school has some quality control over that preceptor. If the preceptor's not teaching the curriculum correctly, they can get rid of them. And that's the benefit of paying somebody. You have some control over the quality. I know a lot of students that, they went with a preceptor at an office, like a primary care office. He had no idea what type of training they were really getting. I mean, they were just getting their book signed that they were getting X number of hours. And so, a lot of them, I think they graduated and probably didn't learn a thing at that clinical site. No quality control when you do it the way that it's being done right now in most programs. So, but will it ever change? Probably not. Yeah, clinical sites you no longer go to because of those situations. Yeah, this was another thing that when I was teaching, and you'd be assigned a certain number of NP students that you would have to go and do clinical site visits. And I would do it. I would, go and visit their preceptor and, maybe spend an hour or so at their clinical site, just sort of seeing what they were up to. And almost every single time, the preceptor would say to me, "You're the first person to ever come here. and A, meet with me, and B, check out the clinical site. And I've been precepting for this program for, 10 years or 15 years. And I know that that's true, that most of the professors never did clinical site visits, never had any idea what their students were actually being taught or who was teaching them, or whether they were even going to clinical for that matter. And I know that that happens too. There's a lot of ghost clinicals that occur in some programs. It's just, it's the way that they're set up. So we had an instance during a surgical observation day. One of my classmates was watching a rotator cuff surgery, and all of a sudden, all the lights and monitors went off and everyone froze. Someone stepped on the main plug for the equipment. Ended up being one of the surgical nurses, but my classmate was blamed. Yeah, of course. That's an easy one, right? Yeah. I thought you were going to say that somebody passed out and maybe fell over the cord or something, because that invariably happens. I had a resident, one of the medicine residents. Our medicine residents rotate through all the departments of the hospital. And like I said, I do wound care and hyperbarics also. So one of the medicine residents was with me, and I was doing a wound debridement. And, wound debridements on wounds that are already pretty nasty, and you're debriding them, and, it can be a kind of a nasty process, but it doesn't bother me a bit. For whatever reason, it doesn't bother me at all. But this poor resident, next thing you know, out of the corner of my eye, I could see her starting to go. And I could not get there in time to grab her. Plus, I had gloves on and everything else. But down she went, and she was so upset, so embarrassed, but so worried. She came to me and she said, "Is this going to affect my evaluation? Is there anything I can do to remedy this?" I mean, she was so worried that I was going to write up a bad evaluation on her. And I said, "No, I'm just, I'm concerned that you hurt yourself, and just sit down, relax, take it easy. Everything's fine, I said, I want you to be well, because who knows, you might be taking care of me someday. So, but it happens to everybody. I can remember one time when I was in the OR watching a case, and I think it was simply because I was standing for so long, not moving, that started to get that feeling like I was going to pass out. I didn't pass out, but I really could appreciate the fact that that feeling indicated passing out was right around the corner. But it didn't happen. Thank goodness. That would have been embarrassing. So no one passed out during clinical, but one of my classmates started having a panic attack and threw up right before a vital signs test. Yeah, I remember, the practical exams where you'd have to, perform a procedure in front of everybody. And even to this day, that kind of stuff unnerves me. So, like I said, I was a paramedic for many years. I was paid paramedic in the 80s. And then I kept my paramedic card, and I continued to volunteer with the fire department. And I did that for, 20, 25, 26 years. And then eventually I said, all right, I think I'm done. I'm never going to be in the back of an ambulance again. I'm not going to need my paramedic card. So in 2016, I let it go. And I figured I was done. And here I am now, 6 months ago, next week, I rejoined the fire department, our local volunteer fire department. And of course, the first thing I'm thinking is I should get my paramedic card back. But I'm going to have to go back through, not the whole course. I can do a refresher and I can test out, but I still have to take the practical exam just like everyone else. and I'm going to have to, demonstrate starting an IV and giving meds and reading an EKG and running a code. And I'm going to have to do it in front of people that weren't even born when I was working as a paramedic. So there's a lot of pressure involved there because I can't screw that up. So I'll probably be doing some throwing up the morning of that practical exam. We'll see. We'll see. Give her crap. Sooner or later, it hits everybody, though, or it comes close. So you have to be humble to some degree because you never know. So I think I titled this whole business tonight, let's talk about why nursing school. So tell me, why did you guys decide that this is, I don't know, a good second career option or whatever? What versus, becoming an airline pilot or something like that? What made you do this? I can tell you why I did it, because I thought that I wanted to maybe move out of New York State and go south. And I was seriously thinking, okay, if I'm going to stay in New York State, I'm going to, follow the path that most of my friends were following and either become a cop or stay in the fire department, become a professional firefighter. But I thought, I might want to go down to Florida and live down there. And, it's tough to get a job with a fire department outside of your area, You got to take civil service tests and all of that. So that was one of the reasons why I figured, I'll get my RN and then I can probably go wherever, And here I am. I never left New York State. So So if you went back to school, it would be for nursing because there's a million things one can do with an RN. And that is so true. And that's why that video that I did the other day showing the decline in RNs, the RN to BSN program, I think that's an indicator that, first of all, RNs probably aren't as interested in getting their BSN, but secondly, there's less RNs to get their BSN. And it's too bad because, there are certain areas of the profession that really suck, but there's also some niches that are really, really good. And if you keep your eyes open and if you're a little bit lucky and a little bit wise, you can do pretty well by getting your RN. Let's face it, the money is not bad no matter where you work. I mean, the money is not bad, and it's available no matter where you go, no matter what state, no matter what country. So I think it's kind of a no-brainer. If you're really wondering what to do with your life, you should put this on your list of possible considerations. Get your RN. And then, again, I mean, if you want to go to medical school or if you want to continue on and get a doctorate or get a PhD or whatever, you probably will find a way to get it paid for. That was what I did. I mean, I never paid for a penny of anything. My diploma program, my bachelor's, my master's, that was all paid for through my hospital. My DNP was scholarshiped, and my PhD was scholarshiped. So never paid for any of it, so can't complain. So I got all those letters. Not doing anything with most of them, but at least I got the letters anyway. Starfish, you were saying that if my mom had a heart attack, had open heart surgery, I saw how the ICU nurse functioned and recommendations CRNA school. Yeah, boy, sometimes it's just an experience like that is all it takes to really set you on that path. And good luck. I really hope that you can do that CRNA, and I'll be very jealous of you. Because I really think that is a very cool, again, that's a niche that you can get into where you can obviously get paid very well. And I'm not saying that everyone that does it is in it for the money, but let's face it, you can make pretty darn good money. It's very respected. It's narrow in its focus, which is nice because you can get really, really good at that relatively narrow spectrum of healthcare, delivering anesthesia and pain management, that sort of thing. I think that's cool. I think that's what I enjoy about wound care and hyperbarics is that most people don't want anything to do with those wounds. Those wounds are disgusting. They don't want anything to do with it. And they have no idea what hyperbarics really is. They know that it's some sort of a oxygen chamber, but they really don't know much more than that. So it's this kind of like secret specialized area. And it's a very narrow focus. I mean, you don't need to know a lot. I mean, hyperbarics, there's a lot of, gas laws and stuff that you have to understand, Charles' law and Boyle's law and that sort of thing. But it's kind of nice to have like a little narrow spectrum and know it well and get really good. So if you're into anesthesia or pain management, that's cool. When you go to the emergency department, you have to know a little bit about everything, but you don't know a lot about much of anything other than how to resuscitate somebody, But you're always the novice in the eyes of the specialty services that you're consulting. So, you may kind of know the picture of gallbladder disease pretty well, and, you can kind of talk the talk with the surgeon. But in the end, the surgeon is just going to say, oh, you're just the ER provider. I'm the surgeon, so get out of the way. But good luck with that CRNA. I think that's awesome. My cheeky answer when anyone asks me why I decided to go to nursing school is money, power, and access to narcotics. Yeah. Starfish, I love wound care. Have you, I did a wound care rotation a few weeks ago. It was interesting, pretty chill. All the patients were good. That is so true. And this is what I tell my ER folks is that you can work in the emergency department and you can meet some really nice people and you can have some really, really good experiences. And I'll say that I think because of my age and that I've been around and I've got white hair, I think people are more chill with me. And I do care about taking care of them. And so I don't have many bad experiences or confrontations with people, but it does happen, and I see it happening all around me. But when I go to the wound clinic, I mean, these are people that I see every week, sometimes for years. I mean, I've been in wound care now for, 10 or 11 years. And I mean, a lot of these people, they get to know a little bit about me. I get to know a little bit about them. Each patient, I've got something in common with them, or I've got some sort of ongoing story to talk about. And it's enjoyable, to say the least. And at the same time, they're so thankful that you're taking care of them, even if the wound isn't really healing. And, some of these folks have such bad vascular disease that just is not amenable to, bypass or revascularization or anything. You can't really fix them, and you can't fix their diabetes, but just the fact that you're trying to do something. And on top of that, I feel that I've got to give them a few minutes of my time and have a nice conversation. But in the end, they're very happy. They're very nice. It's so rare to have a person come into the wound clinic that is nasty or mean. And the same thing with hyperbarics. When people decide that they want to undergo hyperbaric treatment for let's say a diabetic ulcer or something, they've already done their research. They've already gotten a pretty good idea that it's going to be a time commitment for several weeks. But they look forward to seeing you because we'll treat them 5 days a week, usually for 40 treatments and sometimes more than that. So you really get to know people really well, and it's very enjoyable. And then there's the emergency department where, you get to know some of those people, but they're usually the ones that you see every single day. And they're not people that you necessarily want to share much of yourself with them. I don't know. I'll say this because this was on my mind today. I was wondering if the guy was going to show up today. We have several people that just they come in the ER probably around midnight, and they're basically looking for some food and a place to hang, and so they'll say that they have a headache or whatever, and they wind up getting put in a chair in the hallway, and there they sit all night until 7 o'clock in the morning when somebody like me comes on. And it's almost like my job is to just kind of go through and see them all and kind of clean it up and take care of them. Hey, do you need new socks? You want a turkey sandwich? Whatever. Here's a Tylenol. And usually they're all, by 7 or 8 in the morning, they're all ready to kind of go on and get out of there anyway. So I had seen one of those guys that is in the ER almost every day. And he's kind of a unpredictable guy. You never know for sure what you're going to get with him. And he was cool, though. He's really chill. He says, I got a headache. And I said, well, let me get you a Tylenol. And he says, I need some socks, some of those hospital socks. I'm like, we'll get you some of those. And so we did. And I go to see another patient. And next thing you know, I hear this crashing noise. And I got my stethoscope in my ears, examining another patient in the hallway. So I didn't quite hear how loud it was. But I look over, and he had stood up, and he had picked up a treatment cart. It's like a suture cart. And, picked it up and threw it and dumped it. And now he's kind of, standing off with one of the nurses, and then security gets over there, and he starts drawing back with them. And then he goes over to one of our secretaries, and he kind of pulls back on her like he's going to punch her. And that's when more security shows up, and eventually they wind up taking him down to the floor. And then we have university police that show up, and they handcuff him. And I'm thinking, this is at 7:45 in the morning in an emergency department. And most people would not believe that that's the kind of stuff that happens. And obviously somebody could have really got hurt. If this guy really had a chance to take a swing, he's not a small guy, and he's not an old guy. He's a young guy, so he could do some damage. But you transition from that to going to the wound clinic, where everyone is just happy to see you and smiles, and everything is nice and quiet and calm, and nobody dies in the wound clinic. That's a beautiful thing. So you change the wound dressing, Starfish. Yeah, that's cool. We do a lot of biologics in our wound clinic. We do skin substitutes like Apligraf and Epifix and some other similar products. And these are all pretty much derived from either neonatal foreskin, which is live tissue. It comes on essentially a petri dish with agar around it, or Epifix, which is derived from placental tissue. And then we were getting tissue also that was called Epicord, and it was derived from from the cord. It was, but it's right now it's off the market, and I'm not sure why. I'm not sure what's going on with that, but we use those biologics quite a bit on wounds that are non-healing. If there's really no progress in 4 weeks, we have to go to the insurance company and request authorization. But we use that quite a bit. And then, of course, we have a lot of specialty dressings that I'm sure you're familiar with. The different kinds of like absorptive dressings and alginates and collagen dressings. Kind of neat stuff. So the wound care clinic was basically run by the nurses. Providers did see a few patients for debriding. Yeah, most of the patients were just there for a nurse visit. What's weird is in the hospital, we have a wound care team in the hospital, but they're not a part of us. We're the wound care clinic. We're in the hospital, but we're considered an outpatient clinic. And we don't have any connection with the inpatient wound care team. And the inpatient wound care team is just nurse practitioners. And they don't debride. They don't really do much of anything except they give dressing recommendations. And their choices of dressings are pretty limited, too. So, but in our wound clinic, I mean, they're seen by, I'm the only NP, everyone else is a physician, and there's 4 of them, so there's 5 of us all together. And yeah, I mean, most wounds will debride every week. Serial debridement usually results in more rapid healing, so we'll do debridement. Also, like venous stasis ulcers, the nurses will do the wraps. We'll do compression wraps. To be honest with you, I've never put a compression wrap on. I would probably screw it up so bad because a compression wrap has to be put on a very special way with a certain amount of stretch on that bandage in order to get graduated compression from the ankle up to the knee. Yeah, these are things that maybe I should talk about more on this channel, since wounds are kind of a specialty thing, and I think there's a lot of people interested in wound care. I know that there certainly are a lot of venous ulcers and things like that. Whenever I go to the grocery store, this is kind of how sad it's gotten, but during the summertime when people are wearing shorts and I'm standing in line at the grocery store, I'm checking out people's legs and ankles. Kind of evaluating how much lymphedema this one has, or this one has stasis dermatitis, and this one has, hemosiderin deposition with that dark staining, and so yeah, it's kind of bad. Never really paid attention to that stuff before, but now that's the thing. Basically, like, nurses are always, I guess, looking at your veins to see, whether you might be a good IV stick. And here I am checking out lymphodematous legs. That's what life has become. So Schmitty, so since you've graduated from several programs and taught numerous students, what are some gifts that you've seen or heard people getting themselves when graduating? Oh, let me think. Are you looking to get rewarded? Well, I'll tell you. I'm probably not a good person to ask because I don't know. I'm not a big gift receiver, and I guess I'm not a huge gift giver either. But it's a good question. I don't know. I mean, I've known some people, I guess, that, if they're married, their significant other, takes them on a trip or, does something like that. I've never had that happen. But, you know, if you can make it through a nursing program and uh, successfully pass all the exams, I think that you have earned something. I never say deserve. I have a real problem with the word deserve. I don't think anybody deserves anything. I think you earn. And if you've passed a program, then you've earned something, whatever that may be. Buy yourself you know, a new jacket or something, or whatever, go on a trip or whatever, but do it because you've earned it and not because you feel that you deserve it. You're planning on buying a nice watch that you can wear for your first job. Just don't buy one that's going to get all scratched up, because the first time you wear that thing, something's going to happen and it's going to get all sorts of scratched up. So, Starfish, I have seen a new Jeep given. Yeah, that would be nice. Hey, there's Adam. Adam, I've seen you comment on my little tiny YouTube channel before. I hope everything's going well with you. Adam says, what's your take on the opioid epidemic? I'm in Nashville, and it's degrading our city. Yeah. I mean, it's obviously it's bad everywhere. I'll tell you that back about, I'm trying to think when this was now. I'm going to say probably like 2012, 2013, 2014, in those years, in New York and in upstate New York, where I'm at, we had this massive influx of what the street called spike. Other people called it spice or K2, but it was like a synthetic cannabinoid, and on top of that was bath salts, which became a huge thing. And we were seeing a ton of that. We weren't seeing as much of the opioid problem until after that wave went away. Then the heroin really started to kick in. And yeah, we went through a period of time where, of course, Narcan wasn't in every cop car, and people weren't walking around with Narcan like they are now. If I write a prescription, I mean, I did today, I wrote a script for like 4 hydrocodones for somebody because they had kidney stones. But I have to write a script for Narcan to go with it every single time now. That's something new. But I think that right now I'm not seeing as many overdoses coming into the ER, and I haven't in the last year. So either heroin users are managing it better, or there's more Narcan out on the street, or they're dying without making it into the ER. And interesting thing, I don't know, Adam, if you've witnessed this, but I've had a lot of people tell me that if somebody dies from a heroin overdose, the first thing that all the other heroin users want to know is where'd they buy it from, because they want to go buy it from that same vendor, because that must be really good stuff. And they say, I won't overdose on it like that dude did, but that's the stuff I want. So when the first time I heard that, I'm like, wow, that's pretty dark, but also very true. The word gets around the street very quickly. When you start to get 3 or 4 overdose deaths, everybody wants to know who sold it so I can go get some of that too. And another thing that shocked me when the heroin overdoses really started, and I would talk to people in the ER, you'd recover them, whatever. Some of them would get really pissed because you gave them Narcan, you woke them up, and they're angry as hell. And a lot of them will just, like, as soon as you recover them, they're grabbing their stuff and they're walking out the door. They're out of there. But a lot of them are also really super articulate people. who can carry on a great conversation. And it's always left me wondering, wow, how did you get to where you are, and what prevents me or anybody else from getting in that same boat? Because a lot of these people they're not dumb. They're smart people, but they had one experience with heroin, and it just led them down a path. And I know they all say that as soon as you have that first time, you're chasing that first time for the rest of your life, and that's a horrible thing. But is it really bad down in Nashville right now? I'd love to go to Nashville. I've never been, but I'd love to go. But yeah, what a shame that it's still going on, you know. Doesn't seem smart, especially since it's being laced with fentanyl. Yeah. I mean, fentanyl is just in everything now. The fentanyl is so cheap, and it's showing up in everything. And you know, they've recently, not recently, it's been a couple of years now, they legalized marijuana in New York State, but they haven't really legalized the way to buy it. Now, there's only a few places in the entire state that I guess you can legally buy it. And so a lot of people are still getting it, you know, through the black market, and a lot of that is getting laced with fentanyl. It's just crazy. Crazy stuff. I think I'm like one of probably 2 or 3 people in the entire state of New York that has never smoked weed. I was just never around it. It was never a thing. You know, when I was in high school, it wasn't really a thing. And graduated high school, and, you know, I got in the fire department, and it was not a thing there either. Beer drinking was a thing. Beer drinking was a big thing. But smoking weed, it was never a thing. And it just was never like really in my circle. But I would bet now a lot of the folks that I work with in the ER, especially a lot of the docs that I work with in the ER, I'm sure probably a lot of them, not only did they partake quite a bit in school, but they probably are still partaking right now. It's just educated guess that I think they are. Yeah, people do get pissed when you give them Narcan. And, you know, back when Narcan like first came out in the EMS days, we would give 0.4 of Narcan, which was probably the correct dose at the time. But then the protocols changed, and we were to give 2 milligrams of Narcan to any suspected overdose out in the field. The result of that is you went from 0 to 60. You went from somebody that was completely out to somebody that was ready to tear your head off. And so we finally learned, it's only taken like another 15 or 20 years to learn that, you know what, maybe we should kind of go back to that 0.4 milligram dose and, you know, maybe titrate it a little bit until, you know, maybe you get them to wake up a tiny bit, and maybe just stop right there. As long as they're breathing, you know. So I think it took a lot of people probably getting punched in the head before we started to realize that we need to titrate that dose a little bit. Oh, Schmitty's. Oh, boy. Have you heard any rumblings about masks and mandates coming back? My hospital still has a mandate. We got rid of it for a while. And then about, I don't know, a month and a half. Has it been a month and a half or 2 months? We were mandated to wear a mask, you know, in any patient care areas and all that kind of stuff. And I mean, my own personal feeling is this. I think that there needs to be a lot more humility and honesty amongst people who stand up and tell you that this mask works and this vaccine works and whatever, because you know what, we don't have enough data to really know one way or the other. And that's all anybody's asking, is we just want to know, should I be taking this vaccine? Should I be wearing this plastic mask that without question probably has loosened microparticles, microplastics that are probably being inhaled? I mean, that's my feeling. That's my worry. You know, you just want some honesty, but it just seems like even right now, everyone is so, you know, your authorities are so darn sure that they know, okay, you should be doing this and this and this. Well, how do you really know? Because at the beginning, you kind of acted like you knew, and then we find out you really didn't know. So, I don't know. Yeah, we're supposed to be wearing masks. I mean, I think, you know, if you walk through our hospital, most of the masks are underneath the chin most of the time. For me, it's just because, I mean, if I'm wearing that thing all day, forget it. I mean, back of my throat's getting raw and sore, and I know it's not just like dryness that's causing that. It's crap that's coming off that mask. And if you get a little bit of stubble and you're wearing that mask, after an hour or two, you've loosened that up pretty good. My opinion. I have no data to back up what I'm saying. I mean, I could be absolutely wrong, but there is a paper that I did share in a video a long time ago. It's a paper that came out of China right at the very beginning of COVID. And it talked about the microplastics that were being released from these melt-blown plastic masks, the surgical masks that we all wear, and that those microplastics are going to be inhaled. And where are they going to go? Well, they're microplastics. They're going to be able to get right down to the villi and probably cause an inflammatory response, if not fibrosis, and you know, who knows. But there's so little in the literature about it. I'm sure there are people that have done some research, but you can't get it published. And so most of us will not be able to come across it. I heard about a thoracic surgeon in California that was doing bronchoscopies and trying to determine to what extent there could be lung damage as a result of wearing melt-blown plastic masks. But I have not seen the data, and you can't find it in the literature anywhere. In time, the truth will come out as to what we did right and what we did wrong. For right now, I think it's all still pretty politicized, unfortunately. And I think all of us just want to do the right thing. Whatever the right thing is, let's do it, you know? Boy. So I don't know. Are you guys having a mask wherever you're working at or living at? Is that coming back where you're at? I mean, I think if certain people had their way, we'd be in masks permanently, 24/7. But so, Adam, you've been in nursing since you're 18. Weed is still taboo in Tennessee since it's not legal for recreational use. Yeah. Yeah, I think now it's got to the point. I mean, I don't really go to concerts. Once in a while, I'll be around, you know, maybe like a crowd of people, and you can smell it, you know, and people are openly smoking it. But from what I hear, people that I know that go to concerts around my area, it's being openly smoked. I mean, it's no big deal. The cops don't care. Nobody cares about it. You know, it's New York. New York's pretty liberal. And as far as I'm concerned, as long as you're not driving, you know, I guess you're probably okay. I think that's the hard part, though, is how do you figure out who's under the influence by smoking it, unless you can smell it. I don't know. So, Schmitty, you're in Minnesota. No masks in Minnesota. Good for you. I hope it stays that way. I mean, I can feel it right now, just like I said, I think 13 and a half hours. I had the mask on, off, on, off, on, off throughout the day. But, there were times where I had to have it on, to make it look good or whatever. But I've noticed that most patients, they're not wearing the mask anymore either. I think most people are pretty much over it. But just wearing it just as much as I did, it's just made my throat so like dry and raw, which is why I'm drinking my water here. So let me ask you this before we sign off or whatever. How does Wednesday nights work for you guys? I mean, is Wednesday nights a pretty good night to get together and do live stream? I typically work Mondays, Tuesdays, Wednesdays, occasionally Fridays. And then I'm usually on call Saturdays for hyperbarics for 24 hours. And I just like the idea of doing live stream and just kind of listening to what you guys are up to. And, over time, I think we get more people involved. We're going to really learn some stuff from each other. I've had an idea of creating a website where people can just like write essays about, I don't know, healthcare experiences, things that they have learned or done, or pearls of wisdom or whatever, and send it to me. I'll edit it and then post it in perpetuity on the website. Kind of like, it's a website called Medium that I came across, and it's like, if you want to be a writer, you can write and submit, and they'll publish it, put it right up there, and you can have your works read by lots of people. I think that'd be a cool thing for healthcare providers, because I think we all have some experiences that we probably want to share with others, but we just don't have a way to do it. I mean, you can't. Well, there's really no way to share it unless, I guess, you're on like a Facebook group or something like that. So you're passing meds and listening. Wow, good for you, Adam. Yeah, Schmitty, Thursdays are your day off from school. That's the thing. Typically Thursdays are my day off, my day to kind of catch up on paperwork and Zoom meetings and all that kind of stuff. So even though I'm pretty beat by Wednesday night at 9 o'clock, I figure this is probably a good time to just kind of sit and chill and talk a little bit. So I'm going to keep trying to do Wednesdays as long as somebody's interested, even if it's just one or two of you. Well, Adam, I don't want you to make any mistakes passing meds. So don't let me screw you up, and don't blame me for, if you make a mistake. But I know you won't. You've got to be a good nurse. It sounds like you've been in the business for a little while. Well, I think we'll sign off. Maybe we can all get some sleep. 7 nights at all times. You know what I've wondered is whether, if I just like went on randomly, would anybody even know? I mean, or is it 8 nights? Yep. Blame the New York guy for any med errors. Go ahead. You're going to blame me for stuff. You got to stand in line. Well, listen, my friends, I appreciate you joining me. This has been a lot of fun. It's been a lot of fun. I've had a chance to play with the technology a little bit and learn how to live stream. It's pretty cool. And I'm going to try to make a couple more videos here this week, and then be back on next Wednesday as long as you all are interested. So until next time, I guess we'll call it quits. Keep in touch, and I'll talk to you all soon, okay? Have a good night. Yeah, my pleasure. My pleasure, man. Yeah, let's. I appreciate your time. I appreciate you guys being with me. That it means a lot, and yeah, let's shoot for every Wednesday, and who knows, someday maybe we'll do it every night. Kind of like back in the days of the CB radio. You guys aren't old enough for that, but when I was a kid, I had a CB radio, and I'd stay up until 2 or 3 o'clock in the morning talking to strangers on that radio. That was good, clean fun back in the day. All right. Y'all have a good night. I'll see you.